Hello, everyone, and thank you so much for joining today's educational webinar with Cancer Support Community Los Angeles. I'm Kathy Riley, the Associate Director of Programs at CSCLA. I'm honored to welcome you to this week's webinar titled Radiation Oncology, an Overview. Before we begin, if this is your first time joining us, Cancer Support Community Los Angeles is a premier nonprofit organization providing vital social and emotional support to families facing cancer, including patients, caregivers, and their loved ones, all at no cost. Our programs include support groups, healthy lifestyle classes, social activities, and educational programs such as this one. If you would like to learn more about our services or watch past webinars, visit our website at cancersupportla.org. Before I introduce today's speaker, please note that your video and microphone are automatically disabled for this webinar. You may, however, enter your questions into the Q&A feature found at the bottom of the Zoom window at any time. Questions will be answered at the end of our presentation, but also our speaker is going to pause a couple of times throughout her presentation. We may not get to every question today, but we'll get to as many as we can. Dr. Priya Mitra is a clinical assistant professor of radiation oncology in the Department of Radiation Oncology at the Keck School of Medicine. Dr. Mitra received her MD degree from Northeast Ohio Medical University and completed her residency in internal medicine at Boston University Medical Center. She completed her radiation oncology residency training at Virginia Commonwealth University Hospital. She has been board certified in internal medicine and is currently board certified in radiation oncology. She was an attending radiation oncologist at Einstein Medical Center in Philadelphia for 9 years, where she co-chaired the Gynecologic Oncology Tumor Board and had a special interest in women's cancers. Dr. Mitra's focus is to teach residents and medical students at LAC USC Medical Center and to treat patients in the USC Orange County satellite locations. She is also committed to serving the community and works very closely with local domestic violence shelters, promoting women's health and education. It gives me the greatest pleasure to introduce you, Dr. Mitra.
Thank you so much, Kathy, for the kind introduction, and thank you all so much for joining today. Let me share my screen. Can you see the screen okay? Are we good?
We are good.
All right, so we'll get started. As Kathy mentioned, I will be pausing at a couple points. Please feel free to submit questions as we go. I'd love to answer them to the best that we can. All right, so just again, a summary of a little bit of a background. I currently work for USC Hospital. I'm an assistant professor there in the Department of Radiation Oncology. I am an Ohio native. I went to medical school at Northeastern Ohio. I then did internal medicine residency in Boston, and then I went to Richmond, Virginia, where I did my radiation oncology subspecialization. I worked for almost 10 years in Philadelphia, was briefly at UC Irvine, and now I'm at USC, where I've been for the past 2 years. So my objectives for today are three. So the first is to just give you an overview of radiation oncology. Secondly, we'll go through the workflow of what happens when you walk into a radiation oncologist's office and what are the next steps after that, and what are key things to make sure that you're asking your doctor and things that you should make sure to tell your doctor, because it's a very different scenario and different field than medical oncology or other specialties. And then we'll talk briefly on the future of the field. So starting with overview of radiation oncology, I wanted to start with a little bit of history. I thought this would be a little interesting just to know that radiation has been around for a long time, over 100 years. So X-rays were originally discovered back in 1895 by a German physicist by the name of Röntgen. This is a picture of him on the right and a picture of his wife, and she was the volunteer for the first X-ray of the human body. You can see a picture of her hand with her wedding ring on, and this really was the starting point of radiology and radiation. So a few years later, in 1898, Becquerel, who's an engineer, and Marie Curie, who you may have heard of, a physicist, discovered a couple of the elements from the periodic table. And they discovered that these elements, uranium and radium, had radioactivity. So then when they started to discover this, they also realized that it was causing burns on the skin with contact with those radioactive elements. So they started to use it on the skin. They would treat growths on the skin, such as lupus, skin cancer, acne. But as you'll see, these are some non-cancerous things that they were using the radiation for. So there's some pictures here in 1905. This is a patient here where they had radium salts that they literally would tape to the patient's face where they thought that she had lupus or some sort of skin condition. So you can see it taped there. On the top right, they also realized that it was possibly affecting infections for the better. So they started using it to treat tuberculosis. This is again the early 1900s. Here's the machine, and it's aimed at the patient's chest. They also started using it for hair removal. I had one patient who had it was treated in the early 1900s with axillary sweating. They thought it would help with that. On the bottom right, there's a picture of another X-ray apparatus, and they had put a shield where they would cut out to protect the rest of her face, and they would target the radiation just at that portion where she had a skin growth. I thought this was kind of interesting. So when it was first discovered, they thought that it was magic in water. So they actually had these water dispensers that had radioactive radium inside. And these are some old ads from back in the day where it was saying that it was a high and measured dose of radioactive drinking water, and it would treat all these disorders, gout, neuralgia, sciatica, diabetes, all these things. And they thought it was going to cure the world. They also had this, again, another water filter, and here was a powder, radioactive powder that people were putting on their skin. Well, surprise, surprise, safety concerns started to come up when several workers in a lot of these radioactive factories began to have health issues, some of which even died. So with further study, they realized that shorter, more frequent treatments was safer, and that's how we do treatment today. As opposed to taping on a radioactive salt onto the face, instead we do much more calculated, smaller doses and exposures to radiation. So how do we treat cancer today? Generally, there's three main treatment options. So surgery or an operation, chemotherapy, which is basically a medicine typically, most commonly that's given intravenously through an IV, comes from the word with chemical. So it's a chemical or medicine, almost like an antibiotic would treat an infection. Chemotherapy treats cancer, and radiation, which is what we'll focus on today. There's another treatment option that has become very popular and had a lot of success with that, which is immunotherapy. And that is also kind of revolutionizing the cancer world, which we'll talk about a little bit later. So what is radiation? The technical definition is that it's energy that comes from a source that travels in the form of a particle or wave through space or a material medium. On the right, there's different types of examples of different types of radiation. So things that we use commonly, like a microwave or light, radio waves, these are all types of radiation. Particle radiation, alpha, beta, proton, neutrons, ultrasound, if any of you have ever had an ultrasound done. In gravity, there's also radiation waves. So this is just another example of different types of electromagnetic radiation that are used for lots of things that we do in daily life. Everything from radio, microwave, all the way to gamma rays, which is on the extreme right, which is what we use for radiation. So a little bit of basic science of different types of radiation. You may remember back from science class in high school or college, you have a nucleus, which has protons and neutrons, and then you have orbits of electrons that go around it. There's two main types of radiation. There's non-ionizing and ionizing. Non-ionizing is something that has enough energy to excite the atom. So for example, in a microwave, you excite water molecules, it creates friction, which then creates heat, which helps then warm the food. Cell phones, radio, all of that uses non-ionizing radiation. Ionizing radiation is what we use for radiation treatment. So it has enough energy to remove one of these electrons from the orbit of an atom. So examples again would be UV light, X-rays, and gamma rays, which is again what we use for radiation treatment. So just as an example, I don't expect, we're not going to go into too much detail, but I just wanted to illustrate that the different types of ionizing radiation that we can use travel and have different penetration abilities. So for example, an alpha ray can get stopped by something as simple as paper. Beta can get stopped by aluminum. Gamma and X-rays can be stopped by lead, and neutron requires water or concrete to stop those rays. And the reason that I wanted to illustrate this is for radiation safety. All of our treatment rooms and where we deliver radiation treatment is shielded with adequate thick typically concrete to help protect patients and staff. So radiation is again a medical specialty that we're using ionizing radiation to help kill cancer cells. So radiation actually causes damage directly to the DNA. And not only does it affect the cancer cells, but it also affects normal cells. So cancer cells themselves have a more difficulty repairing themselves. I like to tell the story to patients of the wolf that huffed and puffed and blew the house down. And you remember there was a straw house and a brick house. And the straw house is like the cancer, where, you know, if the wolf is huffing and puffing, it's hard to rebuild that, which is like the cancer cell. So the more we give the daily radiation, you have a buildup effect of that, where that straw house eventually falls apart, as opposed to the brick house, where you can lose a couple bricks, but you can then repair it. The body can repair itself and recover. Also, cancer cells are growing more rapidly, so they're more sensitive to the DNA damage. And there can be direct and indirect effects as illustrated here. So let's talk about the different types of radiation. So we have external beam radiation or teletherapy or brachytherapy. Now these words originate from Greek origin. So tele, like a telescope, is something that we use to visualize something at a distance. So teletherapy, there's a machine at a distance, it's external to the patient, and that machine emits radiation that goes through the patient aimed at the target. And I'll show you more examples of this, but I just want to give you an overview. Brachytherapy, so brachy is short, is what the Greek origin of that word means. So on the right, bottom right here, there's a picture of a disorder called brachydactyly, which is basically a short finger. You can see that the thumb on the left hand is shorter than on the right hand. So brachytherapy is where radiation is actually placed within or next to the cancer within the patient. It can be temporary or permanent. And again, I'll show you some examples in a little bit. So external beam radiation therapy, this is an example in the center of a radiation machine. It's called a linear accelerator. This is a patient. The patient is laying on a table, and we call this a couch. The neat thing is that this couch, this tabletop can go in and it can slide out. This table can also go up and down, and it can rotate. I don't know if you can see on the bottom here, there's a circle that's not, you can't fully see it, but basically this couch can rotate as well, so that we can really get the head of the machine, which is where this is, out of which the radiation comes, to really aim appropriately at the target. This machine, again, linear accelerator, it rotates 360 degrees. And then we have an isocenter. So imagine like if you've ever gone and done archery or gone to a shooting range or anything like that, you've got a crosshair, right, that you're aiming for. So similarly, we set that crosshair, which we call the isocenter, in the middle of the target. The radiation therapists are part of our team. They are the ones who administer the radiation treatment. It's every day. They are the ones who bring the patient into the room, lay them on the couch or on the table, set up the machine, set up the patient, and deliver the treatment. The treatments are typically given Monday to Friday, 5 days a week, typically lasts about 5 to 10 minutes. Now, how long somebody receives treatment, it really depends on the type of cancer that they have and what the intentions of the treatment are. It can be anywhere from 1 treatment to 8 weeks of treatment daily, Monday to Friday. I like to go over these myths with patients. A lot of times people are afraid to ask, so I usually tell this to everybody based on some questions that I've been asked. So by getting external beam radiation, a patient is not radioactive. They do not glow in the dark. They are perfectly safe to be around other people. So they don't have to use any separate bedroom or sheets or towels or bathrooms or anything like that. They're safe to be around pregnant people. We actually have several radiation therapists that I've seen over the years who've been pregnant themselves, perfectly safe. It's safe to be around children. It's okay to be sexually active. There's no issues or limitations with external beam radiation, generally speaking. You also don't set off metal detectors because the radiation is not within you. It goes through you and sets off that chain reaction inside to help kill, to cause that DNA damage. So some sample durations of external beam radiation treatment. So breast cancer, classically, it used to be about 6 weeks. It has even shrunk down to about 3 to 4 weeks. Lung cancer, sometimes we can complete it within 3 treatments or 3 to 5 treatments. If it's a locally advanced cancer, it's more like 6 weeks. Cancer, when it gets into the brain, if it started in the brain, it's often 5 to 6 weeks, depending on the type of cancer that it is. But if it's a metastasis, meaning it has come from another part of the body, such as the lung or breast, sometimes we can just target it, especially if it's small, in 1 treatment. Rectal cancer historically has been approximately 5 weeks. Newer studies are showing that we can do it in just 1 week to 5 treatments, and it's very successful. Anal cancer, 5 to 6 weeks. In somebody who has end-stage disease, where we're aiming for palliative, basically helping to relieve any kind of pain, such as a bone metastasis or a cancer that has spread to the bone from another part of the body. Sometimes we can treat it in 1 treatment, but classically it's 1 to 2 weeks. But again, it depends on what part of the body we're talking about and if they've had radiation before. So how much radiation is safe? This is a question I get asked a lot. I think when people hear about radiation, they get scared naturally. I remember even when I decided to go into this field, I had a lot of family and friends ask if it was a good idea for me to do that because I may be putting myself at risk. Thankfully, we have a lot of regulatory committees. So one of the most common ones that we often reference is the NRC, which is the National Regulatory Committee. They regulate exposure beyond normal background radiation. On this table on the right, I'm not going to go through all the details, but I just want to point out the different agencies. So the NRC, which I mentioned, the EPA, California, the state has several recommendations, and OSHA as well. As you can see, even just if you look at whole body, if you scroll across this top column, it's all the same. And even for the lens, 3 of the 4 is about the same. Skin, hands, and feet, they're about the same. So it's reassuring that there is some consistency. So generally, generally for the public, it's 100 millirems per year or 1 millisievert. And I don't expect you to remember these numbers, but I just want to share some just to give you a ballpark idea. Radiation workers such as myself, we can tolerate 5,000 millirems per year or 50 millisieverts, as that is a safe limit. So measuring radiation's effects, I thought this was an interesting table. This is on the NRC website. So if you look at above this blue line, if you live outside a nuclear power plant for a year, the number of millirems is only 0.1. And again, remember, for a general public, it's 100 millirems per year that you can tolerate. Flying round trip from DC to Los Angeles, that's 5 millirems. I think that's also a common misconception, not realizing that when you're doing long flights, that can expose you to radiation as well. A chest x-ray is about 8 millirems. A dental x-ray is about 40. Thankfully, we don't get those all the time, not even once a year. And typical yearly dose, 360. And then down below this blue line, typical annual background radiation dose, they estimated it was about 360 millirems per year. The expected impact on life expectancy is 18 days. But as you can see, being overweight and smoking has a much more significant impact on life expectancy. On the bottom right is a picture of a radiation safety badge. We wear them at all times when we're in the department, just so we have monitoring of how much exposure we have. Another interesting fact I found was that there's there is a little bit of radioactivity within food. So all water on Earth contains small amounts of dissolved uranium and thorium. So basically the average internal dose of 30 milligrams per year is from the food and water that we take in. So let's move on to brachytherapy. So as I mentioned, we talked about external beam radiation. Brachytherapy is very, very different. So the radiation, again, is inside or next to the tumor. Broadly speaking, we usually subcategorize it into low dose rate and high dose rate. Low dose rate is slow. That's how it's easy to remember. Low is slow. So basically you put in something radioactive and it slowly releases the radiation over time. These patients do require some more radiation safety precautions rather than the high dose rate. So just a couple pictures. On the top left is a picture of a cesium safe. So if you can see, I used to work with this when I was a resident. In my prior hospital, we had this. So right here, this is a safe box and it's under lock and key. And this is all shielding. This is all shielding to protect. So I would stand on this side and I would look over here and I would work in this space. I'd wrap my arms around and open that lock and key, open up the safe, and I would take out the cesium. So cesium picture here on the bottom left, as you can see, it's pretty small. This, I believe, is centimeters. So about an inch, a little over an inch is one source. And so we would take a handful of these and implant them into the patient's applicators. And I'll show you some examples of that. High dose rate, again, the radiation is emitted quickly from the radioactive source. Less precautions are necessary because it's not in the patient very long. Low dose rate, for example, when we used to treat cervical cancer patients, patients would be in the hospital for anywhere from 48 to 72 hours with the radioactive source of cesium within the applicators that are in the body. So as opposed to high dose rate, the treatment takes about 10 minutes on average, depending on what you're treating. And so we place the applicators, we insert the radioactive source, which is typically iridium. It emits the radiation, the source gets retracted. So if you see on the upper right, this is called an afterloader. This is also shielded on the bottom and the top. A lot of shielding for a source that's really tiny, looks like a grain of rice. And these are catheters that we connect to the patient, the applicators that are inside the patient. You hit a button, the source comes out, gives off the radiation, and then it gets retracted back into the safe. And then we remove the applicators and the patient goes home. So there's generally been a trend in moving in the direction of high dose rate over low dose rate. It's a little bit easier for patients and it's a quicker treatment. So as I briefly mentioned earlier, I used to live in Philadelphia. This was the orange. I don't know if any of you have any Philadelphia connections or have ever taken this. This is the Broad Street line. It's the orange line. So as you can see along the line, there's different stations, right? And as you are on a subway or on a train, the train sits at each one of these stations for a period of time, lets people get on and off, right? Very similar to this. Inside, when we put these applicators inside the patient, there are what we call dwell positions or kind of like train stations. So if you can imagine here, these are different catheters or what looks almost like a flexible straw threading through the breast where the cancer is in the middle of the breast. Within each of these catheters, imagine the subway line and the radioactive source will sit here for 30 seconds, give off radiation, and then move to the next position, give off radiation, and so on and so forth. And therefore, it gives the radiation basically from the inside out, as opposed to external beam radiation, which is going from the outside in. In terms of breast cancer brachytherapy, there's lots of different types. This is interstitial, where we actually thread catheters through the breast. You can actually put a balloon into the breast as well. Again, these are all temporary. We put them in, we do the treatment, and we remove everything. There's also a role for intraoperative radiation therapy, meaning at the time of surgery for breast cancer removal. Sometimes we can give radiation right then and there. You can also put in, this is called a SAVI, it's just a different technique, different applicator. And then this is a non-invasive way of doing breast brachytherapy. So basically it's almost like a mammogram. So you've got two plates where you compress the breast within the plates, and on either side of the plate, there's a circle that has, imagine that train track, but it's in a circle. So the radioactive source will sit at each one of those dwell positions or train stations and give off radiation. So I want to share some more examples of prostate cancer brachytherapy. So classically, the way it's done is we put an ultrasound into the rectum. Of course, the patient is asleep. And so we put this in so that we can use the end of the ultrasound to image the prostate. So this is a patient laying on their back. This is their backside. Here's the sacrum. Here's the rectum. The bladder is here, and this is the prostate. And then this is the urethra coming out through the penis. So we put the ultrasound in, and then using needles, we implant radioactive sources within the prostate. And you can see this is what it looks like on the right. These pellets that are evenly spaced, and these pellets are tiny, as you can see, smaller than the size of a dime. Now we can do this this is classically LDR, that low dose rate where it's slowly giving off radiation. So we put it in, and these, as I mentioned, this does require safety precautions. So for example, we'll tell them not to have any, so a lot of times it's elderly gentlemen, so we'll tell them not to have grandkids sit in their lap for a period of time, depending on the radioactive source that we use. That can impact it, and maybe to avoid sexual activity for a certain period of time. But basically over time, it slowly emits radiation, and then it helps kill the cancer. Here's an example of cervical cancer brachytherapy. So this is something I do a lot of, working at our downtown LA location. We have a lot of cervical cancer, which, because a lot of the women unfortunately don't go for screening, so by the time they come in, a lot of them have advanced cervical cancers. So with cervical cancer, we use a combination of external beam radiation and brachytherapy. So, which is really nice, because if I did all external beam radiation therapy, if I'm going through the body, the problem with that is that it's going through the bladder and it's going through the rectum, and that would cause way too much damage. So we do a combination. We do external beam radiation, which goes through the bladder and rectum, allows the cancer to shrink, and then we treat from the inside out. So what we do is we implant, for example, this is one of the applicators. It's called a tandem and ovoid. So this part in the middle right here is called the tandem, and that basically gets inserted. And again, patients are asleep, they're under anesthesia. We insert this into the vagina. So this is the vagina down here. Here's the cervix, and this is the uterus or the womb. The tandem gets inserted into the uterus, and these are the ovoids on either side of the cervix. And again, remember that train map I showed you? Within each of these, it's hollow. So within the tandem and within the ovoid, you can see actually on the picture on the right, each one of these rectangles represents a dwell position or a different track station. So the radioactive source will sit at each one of these positions. As you can see, there's several on the ovoids as well. This is looking at it head on, and the picture on the extreme right is looking at it from the right side. So depending on the source that you use determines if it's LDR or HDR. The procedure is the same. So if we use cesium, the LDR, that's like what I was mentioning earlier, where the patient is hospitalized in a radiation safe room for 48 to 72 hours. And this is what I was trained on. This is what used to be done as kind of standard of treatment. We would use cesium. HDR, which is how we're doing things now, is using iridium. So basically the radioactive source does not have to sit inside as long as it used to. So on the bottom right, or bottom left, is the light bulb. I like to use this as an example too. If you can imagine, this is the womb or the uterus. This is the cervix, the gray part at the bottom, and then in the middle is the filament. And that's almost like the radioactive element, which then gives off radiation. And you get a cloud in a pear-shaped distribution. You can also use brachytherapy for lots of other sites too. So nasal cancer too. Sometimes if it's right up against a critical structure that with external beam, you can't adequately cover it, you can put catheters in, again, while the patient is asleep. And within each of these needles, which is then replaced by a catheter or that straw-like device, there's different dwell positions or those different stations at which the radioactive source can sit. And then once the treatment is done, we remove everything. So I think we have a couple questions, and I was going to pause here. Kathy, if you could help me with that, please.
Yeah.
Oh, go ahead.
Yeah, we do. Go ahead. Were you going to mention something else before we took some questions here?
No, I see. I'm looking at the questions, and I'm happy to address them. It was a really good question. So questions are about prostate cancer. So what proportion of my practice treats prostate cancer? So I work at two locations. One is the LA County Hospital or LA General up in downtown LA. There, I personally don't treat a lot of prostate cancer because my focus is the cervical cancer and uterine cancer patients. So I really primarily female gynecologic cancers. In my Orange County practice, I definitely treat a lot of prostate cancer. SpaceOAR is something that we use quite a bit as well. That's kind of become our standard protocol. What SpaceOAR is, for those of you who don't know, it's basically a way here. I'm going to actually go back to one of my slides, and I think I can use the anatomy in that picture to show. So if we have a patient with prostate cancer, so if this is the prostate here that I'm circling, instead of using the brachytherapy, what we could do is external beam radiation. But as you can see, the prostate is right next to the bladder and right next to the rectum. And especially right here, the space between the prostate and the rectum is very, very narrow. So SpaceOAR, what that is, it's basically a FDA approved, safe, I guess it's almost like a liquid that you insert in between the space between the prostate and the rectum, and it helps push the rectum away. And it's the beautiful thing about it is once it gets inserted, it within about 30 seconds, it begins to harden, and it creates that gap between the prostate and the rectum. And the purpose of it is to help spare the rectum. It allows us to decrease the side effects to the rectum, so patients tolerate treatment better. And then it dissolves on its own after about 3 to 6 months. So it's been really, really helpful, and I definitely am a big fan of it. It's definitely not a requirement, but it's certainly something that's being used more and more frequently. Any other questions before we move on? All right, I will keep going. So next, what I want to talk about is just the workflow of radiation oncology. I'm not sure how many of you have been in a radiation oncologist office with family, friends, or yourself. But just kind of want to walk through the different steps and then kind of go from there. Please, again, please submit any questions as we go. So the first step is consultation. Usually, it's very rare that a patient will call our office and say they want to come in and be seen. It has happened, certainly, but that's definitely not the majority of cases. They're often referred to us by surgeons or medical oncologists. Most patients already have their diagnosis by the time they come in. And the purpose of the consultation is for us to get to know the patients and to talk about the guidelines and indications for treatment. So for each step in the workflow, I wanted to go to important questions that as a patient or family member of a patient that you should be asking, and make things that I want to make sure that you tell the person, your doctor. So first question to ask is, what is the stage of my cancer? So on the upper right here, there's just a diagram here. I don't know how many of you are familiar with staging, but just in case for those who are not, staging basically tells us how advanced the cancer is. Stage 0, which is really only in breast cancer, meaning it's really, really limited to just the duct within the breast. Generally, most cancers are stage 1, 2, 3, or 4. 1 is very localized. 2 is still early stage, but just a little bit more than stage 1. Stage 3 is locally advanced, and stage 4 generally means that it has spread outside of where it started, meaning it has metastasized. For example, a lung cancer that has spread to the brain. So it's really important to ask what your stage is. Second is, what is the standard recommended treatment for the stage? So we, as in the oncology world, we use what are called the NCCN guidelines. I think that's a great resource too if you are looking for a place to go. They have patient information on their website. It stands for the National Cancer Comprehensive Network. It's almost like a recipe book where it has a lot of evidence-based guidelines of how we treat what we treat. So for example, there's a 100-page document on breast cancer, and within that you can go through, okay, if this is the stage, what should be the next step? What kind of test should be done to work up a cancer of this type? So on and so forth. So it's really, really helpful. I also like to just print the NCCN guidelines that are relevant to the patient, and that would kind of walk them through why we're recommending what we're recommending, and I typically find it helpful. So you can certainly ask your doctor to print that for you. It's important to ask if there's any alternative treatments that they could offer. Sometimes, for example, there may be a choice, like as I mentioned, in rectal cancer, 1 week versus 5 weeks. So you want to ask about any other alternatives. I would also ask, what if I don't do this treatment? Because sometimes patients do come in and say that and ask that question. I think it's a very valid question because we want to make sure that our patients are informed and not force them into doing anything they're not comfortable with. They should know other treatment options. I also love the question of what would you do if you were in my shoes, and what would you do, if I was your mom? And I often try and preempt that by telling them what I would do if they were my family member or if I was in their shoes. I think it's also important to ask about clinical trials, especially, for example, if somebody has a cancer that has come back, and they're outside of the standard treatment recommendations. That's especially when I think clinical trials can be really important and may be able to provide treatment options that you may not necessarily have access to otherwise. It's important to ask if the goal of treatment is curative or palliative, because that makes a very big difference in terms of the long-term game plan. And also asking if there's any more imaging or any other tests or biopsies that are necessary before you can start treatment. Things to tell your radiation oncologist. If you are currently pregnant, that is really, really important to share. We don't give radiation treatment to anybody who is pregnant. So if somebody is premenopausal, so if you've not gone through menopause and you are sexually active, I almost always get a pregnancy test. I recommend it. So obviously patients can decline, but it is something that we typically recommend. I have had a couple of patients with positive pregnancy tests, which then impacted the next steps of treatment. We've also had patients who have been diagnosed in pregnancy, for example, with breast cancer. But then at that point, what we do is alternative treatments such as chemotherapy and or surgery, because we can't do radiation because of the radiation safety guidelines. It's important to mention if you have a history of a collagen vascular disease, such as lupus or scleroderma. Some of those patients, they have a higher risk, potential higher risk of side effects from radiation. So for example, if I have a patient who has lupus and gets a diagnosis of breast cancer, I may not be as eager to give radiation treatment to them, but it depends. Are they followed by a rheumatologist? Are they on medication? How bad is their lupus? What parts of their body are affected by lupus? We had one patient where they had discoid lupus of the skin of the scalp, and there was nowhere else. And so the patient wanted to proceed, and we all felt comfortable, so we did. It's key to tell the radiation oncologist if you have any kind of devices in your body. So when we're giving radiation, especially particularly external beam, so if I have a patient, and I've had this happen, or patient with a left-sided breast cancer who then has a pacemaker right here, that can be a problem because a lot of these implanted devices don't like radiation. So just to give you an example, when we treat breast cancer, we typically give about 50 to 60 gray being the unit of radiation. The tolerance of most average defibrillators and pacemakers is about 2 to 5 gray. So there's no way that can be in the middle of the radiation treatment field. So sometimes that requires removal or moving to either removal altogether or moving to another part of the body. Inflammatory bowel disease. So if somebody has Crohn's disease or ulcerative colitis, and I'm treating the pelvis, that can also be a contraindication, meaning I may not be as eager to treat. So for example, I had a patient who had a very early stage prostate cancer, and according to the guidelines from NCCN, we could either treat them with surgery or with radiation. But he had a history of ulcerative colitis, meaning a high risk of bowel toxicity from radiation treatment. So we opted to steer the patient towards surgery so he wouldn't have to bear that potential risk of side effects. If a patient has had prior cancer, chemotherapy, and or radiation therapy, that's also really critical. I remember I had a patient who had breast cancer. I briefly mentioned she had had radiation to her axilla when she was a teenager because of sweating. So we want to factor that in because we typically don't like to re-irradiate the same parts of the body more than once. Transportation issues. As I mentioned, external beam radiation therapy is typically 5 days a week. So if I always ask, where do you live? Do you have access to transportation? How did you get here? Because if that's not an issue, wonderful. But if it is an issue, that could be a barrier to completing a course of standard recommended treatment. What kind of social support do you have? Do you live alone? Do you have family and friends nearby? That can also impact the success of somebody undergoing treatment. Any travel plans. Now, as I mentioned, it's every day, Monday to Friday. So, it's not advisable to disappear in the middle of treatment. I had one patient who did. She had a family emergency and you can't avoid that, but she was gone for about a week. And sometimes, depending on the type of cancer it is, it can impact success of the treatment. Family history is really important too. For example, breast cancer. Now, only 5 to 10% of breast cancers are hereditary, but if you have a strong history of breast and ovarian cancer that runs heavily in the family, that's really important because then we would make sure to screen for the BRCA mutation, which may require double mastectomy, maybe even removal of the ovaries. I also like to find out what hobbies a person has and what job they do. I had a patient who had a tongue cancer and come to find out he was a chef, and tasting was going to be a side effect, loss of taste. And that was a huge blow to his normal day-to-day routine. I've had patients who are caregivers for either their parents or grandchildren, and they need childcare. And so that can also factor in. So it's really important for us to work together as a team to help patients be able to comply with the treatment schedule. I look like somebody had a hand up. Let me just pause real quick. Is there a risk of lung cancer? Okay, we'll come back to that question. All right. So after consultation, the next step is CT simulation. So what that is basically like a practice run. I like to describe it to patients as, you go to a tailor, you want to have a dress fitting done. You go, they take measurements and they map everything out. And then they say, come back in a week and I'll have your outfit ready. That's what the CT simulation is. We are simulating what the treatment is going to be like. So it's a practice session. So the way that we position a person at the time of simulation is how they will need to be for each of their treatments. So I put some examples here. On the top picture, you can see this is somebody we're treating the head and neck region. Those patients classically are laying back. They've got a little support under their head. They have a mask that is basically, it's a flat surface. They put it in warm water and then they stretch it over the patient. So it's custom fitted to the patient's body and it is fastened to the table. I don't know if you can tell, but these black parts right here, it's connected. So when a patient comes in, they are connected to the table so that it immobilizes them. These lasers, that's that isocenter, meaning what we talked about earlier, where it's centering right in the middle of the tumor. In breast cancer patients, we typically simulate them in this picture, the second picture, where they're at a not fully flat, not fully upright, but kind of in between. We put a cushion under their legs for comfort. Their arms are up. So, if you are uncomfortable with holding your arms up, that may be a problem. So that may be something to share. Down below, if we're treating somebody's pelvis, we often will use what's called a vac lock to immobilize the legs because leg position can affect your rotation and positioning of your pelvis. And then this is a side view. Again, different techniques that we have to immobilize somebody. The key is to make sure that a person or patient is comfortable because this is how they'll have to lay every time. So questions that I would ask, what is the reason for this position? Do I need to be fasting for the simulation? So for example, when we treat stomach cancers, we typically have them come in fasting at least 4 hours before, because if you've just eaten, that can affect how big the stomach is. As opposed to a lung cancer, it doesn't really matter if somebody's eaten or has not eaten. Does my bladder and or rectum need to be full or empty? So for example, for cervical cancer patients, we like to treat with the bladder full. It pushes the intestines up. For prostate cancer, same thing. We like to usually treat with the bladder full, pushes things up. We also want their rectum to be empty. And they usually give you these instructions, but just things to think about. Will I be getting IV or oral contrast? Sometimes we give it for the simulation because it helps us see the inside a little bit better and helps us guide us for treatment planning. Will I have to hold my breath? A treatment technique, for example, that we use breath hold for is breast cancer. So if you can imagine, if you're looking at me, you take a deep breath in, it helps push the chest forward as your lungs fill with air, and it can provide a little bit of separation between the heart and the breast, which then kind of talks about, this kind of goes back to the question that was submitted. Is there a risk of getting lung cancer or damaging the heart if I'm getting radiation to the left breast? Yes. And are there ways to protect the vital organs? This is a perfect example. So getting lung cancer from radiation to the left side of the breast is, I would say, almost unheard of. If anything, what I have seen rarely, but I have seen is what's called radiation pneumonitis, meaning a little sliver of the front of the lung on the side that we're treating with breast radiation. You can get a little bit of scar tissue there, which can cause inflammation in the lung. But again, that's really, really rare. And one of the ways that we use to protect the vital organs is that you take a deep breath in, as I was describing, and that can be really, really helpful. Are there any medications I should not take? So, generally patients can take their regular medications before they come in for a simulation. Medications that we typically want patients to take, especially if they have chronic pain, is pain medicine, which kind of segues into the next slide. which is things to tell them. So things to tell the radiation oncologist would be, are you claustrophobic? For example, that mask I showed you, sometimes that can be really problematic and can trigger claustrophobia. And let's say somebody is claustrophobic and they need a mask. We can actually, sometimes we can apply oxygen, that can alleviate some concern. We can pre-medicate a patient, for example, taking some lorazepam or Xanax can be helpful. We can actually sometimes even make holes or cut out around the face. If you have chronic pain issues, that can be really helpful as well to let us know so that we can have you make sure that you take pain medicine beforehand. If there's any position you cannot lay in comfortably. So sometimes we like to have patients lay prone, meaning on their stomach, but obviously not everybody can lay in that position. So if there's anything that you're uncomfortable with, please make it known. Anxiety is an issue, let us know that too. A lot of times patients will come in for a simulation and they think that they want to please us and they want to follow everything we're saying. But the problem with that is that if you try to be a hero and try and do what you think we want, by the time you come back for your treatment, it's not going to be easy for you to reproduce that every day. And then I've had to sometimes go back and start the simulation process all over again. So the key is to really be honest about what you're comfortable with, what you're not comfortable with. And then if you have any other appointments or time limitations for that day, the simulation takes about an hour, give or take. So if any other time limitations, that should be factored in. So after you've had your consultation, after you had your simulation, the next step is treatment planning. So this is where the patient gets a break. It takes us anywhere, if it's an emergency, we can do it same day, the treatment planning. If it's something that's a little bit more, we have a little bit of time, we typically take anywhere from 7 to 10 days, sometimes longer if it's a complicated plan. And it's a team approach. So not only is it the physician, but we also have a dosimetrist, physicist, and radiation therapist. And it's a bit of an assembly line. So here are some examples of some treatment plans. On the top, you can see this is a head and neck cancer patient. So 3 dimensions, you can see this is looking at them. If you were looking at me, this is a side view, and this is if I were to slice you in half this way. So my job is to outline 3-dimensionally, slice by slice on that CAT scan, the target. We also outline slice by slice the normal organs, things that I want to protect, such as the jawbone, the salivary glands, the esophagus, the spinal cord, all those things, the brain even. In lung, here's the lung, this is a lung cancer, so we would outline our target. And so my job is to outline everything, and then the dosimetrist's job is to help figure out, how are we going to treat this? What angles of the beams are we going to come in with to adequately cover that radiation, our target volume, while sparing the normal structures. Here's an example of somebody who's got a large skin cancer. So again, you can, and these colors, I don't know if you've seen a topographical map where the different lines represent different elevations. That's how we evaluate plans. So here, red, I'm looking at the scalp plan, red is where the target volume is. That's where the bulk of the dose is. And there's a key right here. So, that means that the focus of the radiation is right on the target and very little dose is going to the brain. So things that you want to ask, how many days will my treatment be? How many days a week? How long is it going to take for treatment time? A lot of times we like to give patients their treatment start date when they come in for their simulation. How many treatments in total? We generally know that by the time of the simulation, but sometimes we need to work on the treatment planning to figure out what works best. And I think it's good to ask if there's any chance that you would add on more treatments, because every once in a while we do that. And especially if you have a vacation plan or something or holidays coming up, it would be helpful to know that. I can't tell you how many times I've had patients who come in, they already have flights booked and we're forced to rush and try and, accommodate that, which of course we love to do, but it's the more communication we have on that, the more helpful it can be. So again, vacation travel plans, important to mention. Sometimes patients are getting chemotherapy that's given around the same time with radiation. So sharing that start date is really helpful so we can coordinate with your other providers. Once we do the simulation, there really should be no other procedures, ideally, in the area that we're planning on radiating. So I put an example here. So a lot of times with breast cancer patients, they come in, they have a mastectomy, and then they put in what are called expanders, because they're planning on having delayed reconstruction, meaning they're going to put in implants. But in the meantime, they put in almost like placeholders that they then fill with saline or fluid to help expand and kind of get the skin ready to swap out the expander with the implant at a later time. The issue that we often run into is we do the simulation, the patient then returns to the plastic surgeon, and then they get overinflated. But remember, everything that we do in terms of designing our radiation treatment is from the CT simulation. So for example, in a case like this, on the bottom right, you can see a picture. This is from a CT simulation. The blue box or rectangle represents the area that we want to treat. But as you can see, if the other side is overinflated, it's going to be really challenging to avoid the other breast, which is why we don't want to overexpand somebody. So it just requires a lot of communication between the patient, radiation oncologist, and the plastic surgeon. And generally, we don't schedule the CT simulation until after they're fully expanded, assuming it's close to the surgery time. So then once all the treatment planning is done, patient comes back for treatment. Our job is to meet with patients on a weekly basis. So I have one day designated where that's what I do. I basically evaluate them, and I'm monitoring for side effects. So questions to ask: what side effects should I be looking for? That's really important. That's our job, is to tell you that. But I think it's good as a patient to ask that too, in case that's not being shared with you. Is there anything I can do to limit the side effects? So for example, when patients who need post-mastectomy radiation therapy, there's a cream that we use called Strata XRT, which I have become a big fan of, where basically it actually helps limit the skin toxicity or skin side effects. So there are things that you can do. For example, even hydrating the skin seems to help manage and mitigate some of the side effects of the skin. It's not going to stop it, but it can help. I also think that just exercising and being active and continuing to your normal daily life as much as you can does seem to help too. What happens after I finish radiation in terms of late side effects? So, that we usually divide side effects into short-term and long-term side effects. Short-term is during the course of radiation, and a couple of weeks after. Late is long-term side effects. And so, in the short term, usually we focus on that, and we'll guide patients as to what to look for. The other thing I like to tell patients is that there's a bit of a domino effect, so the effects build on themselves. So the peak of the side effects, the first 1 to 2 weeks, patients often don't really have many side effects at all. And then towards the end of treatment, after treatment is over, the peak is usually about a week to 10 days later, and then things start to subside. And I typically see them back for follow-up in about a month. Things to tell someone, again, if you have any vacation or travel plans, any missed chemotherapy during radiation, because sometimes that may not always be communicated, any new symptoms that you have that you're not sure if it's related or not related. And then the last step in the workflow is follow-up. So we meet with patients after they've completed their treatment every 1 to 3 months. We gradually space that out later, depending on how often they're seeing their other providers and how well they're doing. And they continue to meet with those other team members. So questions to ask: when will my side effects resolve? Are any of these side effects going to be permanent? What are possible late side effects? Now, possible late side effects, it really depends on the part of the body that we're treating. So for example, if we're treating the brain versus the foot, it's going to be very different. I treated a young woman with a foot muscle cancer or a sarcoma, and she required physical therapy because the muscles got thickened in that region, so it became a little bit harder for her to wear comfortable shoes, so she had to get fitted for orthotics, as opposed to somebody who we treated the brain. They may have scalp itchiness that may last for a long time. Now everybody's different, so it's hard to really say this is what you're definitely going to have, this is what you're not going to have. But one thing that you should know is that the side effects are typically related to the part of the body that we're treating. When is my next imaging study? So for example, when we treat cervical cancer, we don't get another scan for about 3 months because the body needs some time to kind of settle down, because radiation can trigger a bit of inflammation, and that can lead to misinterpretation of the results. You want to ask, when am I going to come back for a visit? And what are some red flags that I should look for? When should I call you as soon as possible? For example, I had a patient with cervical cancer that I treated, and we had talked about the fact that she was at risk for potentially developing rectal bleeding. Same thing with prostate cancer. And so she called me, and we got her in to see the GI specialist right away, and they examined her, and it was a radiation late side effect, which was thankfully, fortunately, taken care of. Things to mention, again, if you're going away on vacation, I just saw a patient this week. So our follow-up schedule is kind of around her vacation schedule because she's going out of the country for a few months. If you have any planned chemotherapy or immunotherapy treatments, and if you have any new symptoms, especially in the region of treatment. All right, we can pause there. So another question that came up is about supplements. It's a good question. There's so many supplements out there that I usually involve. So because we've got a large team, I usually involve our dietitian, who's more knowledgeable about supplements. So for example, I had a patient with prostate cancer. I was working at a veterans hospital or a VA hospital, and he was on a supplement, which I didn't recognize. And I just looked it up and turned out it had testosterone in it. And he didn't know it was a testosterone supplement. And we believe that that may have been a link to him developing the prostate cancer. So, the supplements really just depend on what it is. And I usually, as I mentioned, involve whoever's the dietitian on the team. What can be done to mitigate long-term side effects and pelvic radiation disease? That's a tough question. It kind of depends on which pelvic radiation side effects we're talking about. I mean, I guess in general, pelvic radiation, it can cause bladder irritation. It can cause rectal irritation, rectal bleeding. I think sometimes having a colonoscopy before you undergo pelvic radiation can be helpful depending on your age. In terms of bowel toxicity, there's not a whole lot we can do besides we can design our radiation treatment plan to limit the amount of radiation going to the bowel. Bladder filling, as I mentioned, and empty rectum, those are two things that we are finding does help mitigate the long-term side effects. So that can be really helpful. And, that can be challenging at times for patients to maintain a full bladder. But I think that is something that can be really helpful, especially in the appropriately selected case. I think making sure that wherever you get radiation treatment has advanced technology is also really helpful. You can ask about treatment techniques, because I think, asking, for example, the number of x-rays or number of radiation beams that are coming in, which kind of segues into the future of radiation treatment, which I want to kind of will end on that topic. As radiation and oncology, the world of oncology evolves, we're getting better and better. I really do believe that. I think a lot of people think oncology is the cancer diagnosis is a death sentence, but it's really not the case. They're getting better and better with systemic therapy and targeting agents that are actually really, not all lung cancers are the same, which is then asking the question of maybe we don't need radiation. Maybe we don't need surgery. Maybe the targeted agent could be sufficient at, avoiding other types of treatments. And as radiation evolves, I mean, even in the time that I've been in the field, we used, back in the day, they used to literally would take an x-ray and draw with almost like a Sharpie, and that would be the target. And now we're using CT-based planning. And then, in the future, we're talking about MRI-based planning, and we're adapting radiation. So, as the tumor shrinks, we shrink our target. So we replan in the midst of the treatment. We're doing shorter treatment courses. We're getting better at sparing normal organs. So before, for example, it used to be one x-ray from the front, one x-ray from the back. Then we advanced to about 4 x-rays. So front, back, right, and left. Then we did 5, then 7, then 9. And now we're doing rotational treatment where the machine is constantly moving around the patient 360 degrees. And in the head of the machine, there are these leaves which look like fingers. And so the fingers close when the bladder, for example, is right in the middle. And then it opens when the target's in the middle. So it's becoming a beautiful art that we are getting better and better at mitigating these risks. So SpaceOAR is another example, like in prostate cancer, that can help limit things. We also do imaging, which I think is really helpful. So when a patient comes in to lay on the treatment table, we'll take a scan right then and there, and that can help us assess for example, the degree of bladder filling. Are they on the target? So we're doing a lot more real-time management, which I think is also helping to improve things. Is there anything going on with artificial intelligence that will be improving radiation oncology practices? That's a great question. I think there is. So for example, as I mentioned, when we do the CT simulation, my job is to outline the target volume as well as to outline the normal organs. So we now have AI software that is auto contouring, we call it, or auto outlining the normal structures. sometimes even the target volume. So dosimetrists, the ones who actually design the radiation treatment, they also have new software where, before they would have to say, okay, I'm going to try this angle and this angle and this angle. And now the computer program or software is able to design a plan that's even better than them, which has raised the question of maybe they'll be phased out or we don't need as many dosimetrists. I think from a physician perspective, I don't know of anything offhand besides tools that may help aid us with treatment planning. But I think AI is definitely going to affect all of us in all lines of work, and it's exciting yet kind of interesting. So we'll see where that goes. But those are all the slides that I have. I just want to thank you again for all your attention, and if there's any other questions, I'd be happy to answer. Kathy, I think somebody raised their hand. I may need your help with that.
Yeah, if you raised your hand and you have a question, please type that question into the Q&A feature, and we'll wait for that. If you're able to do that, we can't see the question otherwise. And I think they just put it into, there's one more question in the Q&A.
Yeah, so on this, if you can still see my slide, so I work at LA General Medical Center up in LA, and I work at our Buena Park location at USC in Orange County. We, at this location where I'm at today, we have a TrueBeam, which yes, the question is there an SBRT machine? SBRT is a treatment technique that you can deliver with a linear accelerator, which is your standard external beam machine, as I showed you earlier. But the thing is, there's different models, just like like any car or whatnot, there's always a new model coming out. What we have here at our Buena Park location is top of the line. It's a TrueBeam. I wish we had it at the LA General Hospital, but we don't. I'm hoping one day we will get that. But yeah, so we have the capability to do SBRT or stereotactic body radiation therapy at all of our locations. It's just the type of machines that we have. There's a range of how advanced they are. But at our Buena Park location, we definitely have a state-of-the-art, top-of-the-line TrueBeam.
Well, we have reached the end of our time together. If you have any additional questions that weren't answered today, please feel free to email us at info@cancersupportla.org, and I've put that email address into the chat. And also, if you'd like to learn more about Cancer Support Community, you can visit our website. And I want to take a minute and just say thank you. Thank you so much, Dr. Mitra, for that informative and meaningful talk. You covered such a wide range of topics within radiation. So we really thank you for your time. And I want to thank our participants for engaging, for showing up, for asking some really meaningful questions. And again, if there's anything additional we can do for you, or if you have any questions for Cancer Support Community Los Angeles, please email us at info@cancersupportla.org. And we hope to see you at a future webinar. Thank you, everyone. Have a great weekend.
Thank you.